if somebody gave you a true pro and con about the open technique and the closed treatment and gave it to you objectively, not trying to push one agenda or the other, that would strike me as, "Hey, this is a guy who's looking out for my best interest and really wants me to be the best." Because if he's agnostic to doing something that he's paid to do, which is surgery, and he's trying to really give you good advice and advice that is very nuanced and tailored for you, I think that's sort of, you're in a good place.
Unity Physical Therapy. Rogue.
Dr. Timothy Charlton here. You're here on the Beyond the Tear podcast. Dr. Shoyan Safar, Doctor of Physical Therapy with me. Welcome. How's your day going so far?
Very good. How's yours?
Good. I love talking Achilles tendon injuries, all things Achilles on the Beyond the Tear podcast. So today we're going to be talking about probably the question I get. Hey, Doc, what do I do? What am I looking at? The recovery we talked on a different podcast, but it's sort of like on day one, what am I going to do? So we're going to talk about that. And we're also going to be talking about some of the physical therapy elements of that and when you can start to do recovery. We talked about that in another podcast, and we'll be certainly talking about that on a future podcast. But so today we're going to be focusing in on, okay, it's day one. I'm doing my pickleball injury, and we'll start with, when you tore your Achilles and you're mid-30s, elite level athlete, former Taekwondo black belt, stuntman, jiu-jitsu black belt as well. I have a belt. I own one. I have a closet of belts. Some are brown, some are black. None of them are jiu-jitsu. So you're an elite level athlete, and I am the also ran. Walk me through, your mindset of what you were going to do.
Yeah. So as soon as I tore mine, I knew in air, just from my knowledge, that I tore it. So chose not to land on my feet. The only thing I was wondering is, did I partially tear it or fully tear it? And partial tears are very, very rare in these acute athletic things. If you watch the footage, which we can upload, flip, I hear a loud pop. You can hear it. Sounds like a 22 is going off in the distance. Had the classic feeling of someone kicked me in the back of the leg, but knew no one was behind me. Landed, and you can see I keep trying to point my foot to see if I can plantar flex. And then I can, and then little by little it starts fading away. And then I tried taking my shoe off. I checked it. I then put my shoe on. As soon as I stood up, I felt, I have no strength to resist.
Oh, shit. You good? Yeah. Did I kick something? Oh, I think. Oh, no. No? Oh, no, don't tell me. It can't be. Oh, no.
So I knew I tore it, and then I said, "All right."
I'll interrupt so here in Beverly Hills adjacent, it's tennis, it's pickleball, it's my partner kicked me, my partner hit me with my racket. Back in my decade over at USC East Side County Hospital, they said I got shot.
Wow. Yeah.
And that's just sort of, it's county.
Yeah.
But yeah, so you feel you're in the middle of the air, and that's got to be horrifying.
Yeah. And to your point, I know a lot of guys at jiu-jitsu who almost get in a fight with someone because they were doing sprint warm-ups across the mat, and they thought someone kicked them because it's jiu-jitsu. And then they almost get in a fight looking at whoever's behind them, being like, "Why did you hit me? Why'd you hit me?" And they're like, "No." And then they have to, after
Like have a buddy.
Yeah, they're like, "Dude, no one. You were literally by yourself." And then that's when it sinks. But so I tore mine. I knew it happened, and I immediately knew, okay, I can't stretch this thing, so I'm not going to walk on it. I'm going to get crutches. I had a friend take me to the car, and then I went home, and I didn't have a cam boot, so I put towel rolls under my shoe to kind of put my toe pointed, because in a perfect world, what you'd want to do is put your foot in a cam boot immediately, put a bunch of heel wedges in there so that it's pointed. So even until the surgery, in my opinion, you're stuck in plantar flexion, because my theory is we don't want to stretch it as much as we can even before the surgery. And then had some recommendations to call you, and got to see you next day. And then I think that's when I asked you the big question that you get all the time, which is, should I do surgery or should I do this non-operatively? And then, yeah, what do you think?
Well, it's the $1 million question. The answer is, it depends on sort of where you are in your life journey, where you are in your continent of living. Accelerated rehab is the standard of care in Europe. And we're looked at in the United States as accepting an unacceptable amount of risk by operating on Achilles tendon. And there's compelling argument. So you get to this situation for a patient and you're like, it's a very hard conversation to have because you can flip and make arguments on both sides of the coin. And often when you're not doing this a lot, or it's your first injury, first athletic injury, this is brand new for you. You don't know. And then you're looking at sort of anecdotal evidence, ChatGPT, and ChatGPT will take you on both sides and it'll say, hey, both options are viable. And then you're like, well, what do I do? And you're like, I don't know. And I used to feel that it was sort of the argument or the sort of the pitch or whatever you'd say is like, well, what do most 20-year-olds do? What do most 30-year-olds do? What most 40-year-olds do? What do most pro athletes do? So I can say sort of almost universally that most pro athletes with any degree of Achilles tendon rupture are doing something operative. So if that is sort of the gold standard of return to athletic play, that's sort of one end. And then you look at sort of the opposite pole of the spectrum and you go, well, what's the non-operative patient look like? Well, it's sort of a sedentary, I just want to be a household ambulator, older person that really has limited expectations, doesn't do sport, and the risk for them would be infection, which would be catastrophic. So
Infection if they did the surgery.
Infection if they did the surgery, correct? Because when you're looking at, so the biggest issue for all practical purposes with the surgery is infection. So you have to look at that risk aversion, and when it gets infected, it's catastrophic. I mean, it's sort of walk you through like, you can get a little tiny wound infection, or you can get something that's more significant, really red. And the problem is those sutures get colonized with bacteria, and the sutures have a weave to them. They're like abraded sutures. So the bacteria sort of live and hide inside the weave of that braid. So you can never eradicate the infection unless you get rid of the braid. So you've got that. It's an area that doesn't defend itself well. It's a construct of material that lends itself to being harboring and being refuge for bacteria. And then the bailout, it's a terrible bailout. So if you get skin that goes horribly bad, we're not talking kind of medium bad, but horribly, horribly bad, the only option is to have a plastic surgeon come in and do a fairly advanced level flap rotation of some sort of skin coverage that's very, very technical, has its own set of complications in the set that you're looking at the harvest of where do they get the skin to cover my skin. So you get that. And then you also look at what you're dealing with post-surgery from a flap in the best case scenario. So in the best case scenario, you've had this horrible complication, you get infected. And the best case scenario is I got this skin flap with muscle on it that doesn't flow and doesn't sit flat on the back of my heel. And that's the best situation. That's a good outcome from that terrible problem. It's almost saying, I wish I had never gotten the surgery to begin with. Yeah. Now, mind you, that's very rare.
Yeah, I guess what patient would make you worried is if they have a history of any comorbidities or anything that makes you go, oh, this is maybe one we need to do non-operatively.
Good question, because then it also sort of speaks to if their skin on the outside is bad, do they have the biologic potential to heal on the inside? So that sort of gets into, the sort of the thin, trophic, postmenopausal skin in that 65-year-old pickleball player. I theoretically worry about a large incision for that because they lose that fat, they lose that skin viability, they lose the moisture. So, and that's an issue. I think the very heavy obese patients, I get worried about it because when you look at that skin, it's essentially like an orange peel on top of like a thick layer of fat. And I'm not certain that orange peel skin is getting this wonderful nutrition of supportive nutritional blood. It's just sort of sitting on this layer of fat. So I worry about those because if that bacteria gets in there and, you just worry about that. So smokers certainly, patient with diabetes. Yeah. So, I mean, and I think diabetes speaks to sort of the microvascular disease. of how bad is their microcirculation around the skin
Flow to the
flow.
yeah.
Yeah.
So is it safe to say that in general, if somebody, let's say, is an athlete and wants to get back to athletics and they're young and healthy, surgery seems to be the better method for if you want to get back to your athletic potential? If you're older, want maybe a more relaxed lifestyle, or if there's concerns about infection, some things you might want to skew more non-operatively. I know nothing is 100%, but
Yeah. I think it's sort of it's like one vote pro, one vote against. And when you really look at it, the you can make an argument on both sides. So the answer is you can't make a bad choice. Now, I do think, and it speaks to sort of what we're going to talk about today and on the future podcast. So like, hey, what's your goal of surgery? Your goal of surgery is to get the tendon ends to touch and to remain touching through the course of the entire treatment so that they don't stretch out. Now, there is a time sensitive window, and a lot of people, there's a lot of schools in the supporters of non op treatment that are like, yeah, there's a clock on that. There's a short clock to the point of where my partner, Max Mahalski, he basically says, listen, if you don't get in plantar flexion and if you don't get those tendons touching in, call it a 72-hour period, that horse has left the barn.
yeah, I know for me, that's exactly why I put those heel wedges in my shoe. And I got an MRI that day. And even when I was in the MRI, they wanted to put me in dorsiflexion. And I was like, no,
Yeah.
no, 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 no. Keep
Yeah,
my
yeah.
toe. Maybe at the MRI, we'll do non-operative, which we ultimately decided to do operative because of the full tear. I'm very happy with
Yeah.
that. But it
To
makes sense.
just sort of parenthetically or just sidebar on the whole partial tear things. What you see is a lot of people like, oh, did I have a partial tear? And the reason they ask that is because on the MRI, you see the fibers crossing and touching. If you really look at it at a microscopic level, those fibers crossing and touching weren't in their original position crossing and touching.
Yeah.
They have now elongated or partially torn and then so when you see that full tear, then go back and plantar flexion and knit, and on the MRI, you're like, oh, look, they're touching, they're close. Well, you're like, no, they're pretty loose and they need to glue back together again. But that's a full tear, and it's sort of like taffy pulling apart. It's like, yeah, no, look, see, there are 50% of my fingers touching and 100% of my fingers touching there and 50% there. So it's still 50% intact. You're like, no, it's not intact. It's sliding parallel to each other like ships in the night.
I mean, I'll upload mine, but you can see there's a tiny, tiny little white strand connecting. I mean, it's mostly not there. But I remember when meeting with you and you explained that to me and you said, listen, like even though there's a tiny bit touching, it doesn't necessarily mean those fibers are really strong and intact together. And even in the radiologist report says complete tear with maybe a chance at a tiny bit of fibers touching.
But if you're looking at an MRI, it's like, how do you have 90% of your tendon tear and the other 10% still hang on and not get elongated? It's like, it doesn't logically make sense. And similarly, then, and the sort of the red herring of that is, particularly on the medial side, you have a plantaris tendon, which is a little baby, sort of not everyone has it. And that can look like a strand of really good tendon. And you're like, see, that tendon's hanging on. You're like, not really. That's a sort of artifact of being a quadruped, really.
Yeah, we kind of see it with the hands, like the palmaris longus tendon. It's almost like I think the plantaris is almost the same.
Yeah, it's very similar to like, so for example, I don't have a palmaris.
Yeah, I have one on one hand, not one on the other. Yeah. When I teach anatomy students, they always freak out.
That's a little.
Don't have it on my left, and then
on
my right, you can see it.
Oh yeah, look at that. Yeah. So don't get your Tommy John on this side.
Yeah, well, good thing I don't play baseball. So it obviously, like you mentioned, there's no one size fits all for whether you should do surgery or not. I think the other question too is, you mentioned about with someone we're worried about incision, doing a big incision. I know you're really big on the mini open. Can you quickly talk to us about which surgery often do you think is best? Is it case by case, or because there's mini open, there's percutaneous.
So the version, it's sort of an evolution. So if your goal surgically or really non-operatively is to get the tendon to touch, so it's just you can do that by plantar flexing the foot, and so when the ends of that tendon get sort of covered in goo, you kind of need to go and clean that up, and that's the sort of patient comes in neutral position, their foot like the letter L, and they come in and like, yeah, ER put me in this boot and I've been sitting like this for a week and now I see you. So I'm like, well, you're not the best non-op candidate.
Yeah.
So you can go in and you can do a couple techniques. And the point of the open technique is you sort of, to some degree, want to clean up the goo. So there's some value to that. And my mentor, the late Bill Hamilton, pillar of foot and ankle surgery, he made a real point, which is it's a tendon that wants to heal. And I think from an orthopedic surgery perspective, education perspective, you're like, yeah, it's a tendon that, you can make an argument that non-operative treatment is a very viable option, and you're sort of doing an augmented non-op treatment. And if you really sort of approach sort of the mini open or the percutaneous, it sort of sticks to his operative principle, which is the surgery is really meant to maintain that resting tension, to maintain the tension. And I think, you're talking about suture that can do that. And I think it's very effective in that. And that's one of the reasons that you're doing surgery in general. Now, the old school was to do it through an open incision where they do very strong technique and make the tendon and the suture construct very strong where you can't pull it. And from day one, it's very strong. And while that is good, it comes at a cost. You can make an argument that all that suture is just choking the tendon, or that dissection to get the suture in is killing the nutrition of the tendon. So I do a minimally invasive technique for really risk aversion of that infection risk, because I'm trying to minimize that. Now, thankfully, knock on wood, I've had a very low issue, and I'm very paranoid about that. So hopefully that streak continues. So I think the small incision, probably less than an inch, depends on the day, is a better way to go. But there are a lot of people who do it through the open incision and have great success. So I don't think it's necessarily bad. It's just not my cup of tea, because I'm trying to get that infection risk as low as I can. So I've been doing the minimally invasive technique that they talked about. So my old training was, the tool was called the Achilles. It was a French tool, reusable in the operating, stainless steel. And then they came up with a competitor, sort of came up with another device, and they created this device with a couple nuances and bells and whistles that were different for the minimally invasive technique. And that's sort of now, I don't want to say the standard of care, but pretty common. And you see some version of that now with a lot of the pro athletes. What are most of the pro athletes doing? Mostly the percutaneous, with a noted exception of my mentor, Marty O'Malley, who is elite, and he's doing a lot of pro athletes that you would see on the news. And for HIPAA, I won't. Well, I probably could violate HIPAA because I didn't operate him. Yeah, you can say whoever wants. But anyway, he made a point. He's like, he's doing all his pro athletes open. And that gives me a bit of a gulp, to be honest. I go, I don't know about that. Because I inherently think most pro athletes are kind of non-compliant. And they want to, that's like, you get an agent in there and you get a bird chirping in their ear, and those guys want to go, go, go. And if you don't get it, then they're going to lose money. And it's like, I see his point.
Yeah. Do you think he has to almost use the open technique to make more tension, because since they're going to try to be aggressive, he has to sort of counteract that?
Yeah. I mean, he's doing it for a compliance issue.
Yeah.
And maybe we can have him on the podcast in the future of like, hey, why you, that'd be actually very interesting. I'll reach out, and Marty, if you're watching, hello. Cause he does more pro athletes than anybody in the world.
So the other thing I wanted to ask you is, obviously, I was very fortunate to have you, someone who very passionate about Achilles tendon repair, as a surgeon, and a wonderful surgeon, and a very prestigious institution, which is a really, really good sign. But let's say somebody's listening to this and they don't have the fortune of coming to see you. What would be a red flag from their surgeon that would make, let's say, if someone called you and said, "Hey, Tim, my son, my daughter went and saw a surgeon and they said this." Is there any red flag that would make you go, "I think you should get a second opinion"?
Yeah, that's a brilliant question. And I think the answer is when they say you'll be back in 4 to 6 months running. That's like, that to me is a setup for disappointment, and by proxy, sort of a doc who doesn't get it or doesn't do a lot of them. Because if you're saying 4 months before you're running, I mean, no offense, in 25 years, I've never seen that. Or maybe one person. So I look at that and I go, that's an expectation management that maybe they're more sizzled than steak. Maybe they're trying to sell you.
And then let me get you this hot take. This might be a little controversial. How do you feel about podiatrists doing the Achilles tendon repair versus orthopedic surgeons? Do you feel like overall it should be something that maybe orthopedic surgeons do? Are there podiatrists that you trust with this? Because a lot of people I've talked to, they aren't sure. Hey, there's a podiatrist down the street that could get me in next week.
Yeah.
But there's also, I want to see foot and ankle ortho.
Well, I mean, it's sort of my take on it is, and this is, controversial even in the Foot Society. I think there are good docs. I think there are bad docs.
Yeah.
I think there are good podiatrists. I think there are bad podiatrists. And unfortunately, some of the podiatrists is a lot of market driven stuff. So they're trying to tell you things that you want to hear so that you don't leave. Now, if you had, and there are podiatrists here in Los Angeles that are great, to be honest. But on the flip, there are podiatrists in Los Angeles that are not, and they will tell you anything to get you to sign up that are just categorical lies. So I look at that and I think it's sort of like, you got to know what you're getting into and you got to read the room. I think probably the thing that would make me comfortable is the person who said, hey, there's another way about this. The surgery is not the only way. Let me tell you the pros and cons of non-operative treatment. And if you're listening to this podcast, if you're saying, okay, hey, I'm new to this and you're asking the question, hey, what do I look for? I'd be like, if somebody gave you a true pro and con about the open technique and the closed treatment and gave it to you objectively, not trying to push one agenda or the other, that would strike me as, hey, this is a guy who's looking out for my best interest and really wants me to be the best. Because if he's agnostic to doing something that he's paid to do, which is surgery, and he's trying to really give you good advice and advice that is very nuanced and tailored for you, I think that's sort of, you're in a good place.
So it sounds like, to summarize, kind of every case on this is individual in terms of surgery versus non-surgical, right? The best thing is really to get a consult. And then, then there's different surgical techniques that all have their own advantage. And then also, just obviously, if someone's really pushy on a specific thing, that should kind of raise your alarm bells and maybe you want to get a second opinion. And then for those people, if you're listening to this and let's say, unfortunately you have just torn your Achilles, if you can
sorry you did it.
Yeah,
sorry you're watching the podcast if that happened.
But you'd want to ideally keep that foot plantar flexed and in a boot. So for those of you that don't know what plantar flexion, think about like a ballerina pointing their toes versus you trying to make the letter L by bringing your toes towards your shin. So you want to keep it plantar flexed. I bought a cam boot on Amazon. It got there that day, and I didn't have wedges, but I put a bunch of towels under my heel, so it made my toe pointed. I'll try to put a video up there so that if you want to do the non-operative approach, that we're in that critical window of that toe, those tendons coming together. Because obviously, which we've covered in the rehab episode, it's really about getting that tendon to come together, get stiff, stay stiff for a long time before we work on mobility.
I agree. And bravo for that, because that's really, that's it. I mean, I think probably to finish up on this particular podcast, and thanks for listening, everybody. I think that probably the element that if you're going to do non-op, right, like Dr. Safar said, listen, get into the boot early, get your foot in plantar flex as much as you can.
A lot of heel wedges.
Or you can get the Vacoped, which is you can get online. Is expensive.
It's on Amazon too. It is pricey, but
it's pricey. But I don't know if they can get to overnight. I mean, you probably the best thing that you did. You got the tall cam marker, the one up to your knee, and you got that tall cam marker. You got to send overnight. You put the foot in plantar flexion. You never brought it up to neutral like the letter L the entire time until you saw the doc that next week.
Yeah.
And then if you checked those boxes, then I think having a conversation about non-operative treatment is appropriate. I think if you didn't check those boxes and you had that foot like at letter L and you could feel the gap and you could feel that gap for days, that gap's going to fill with goo. And when you put the foot back up into plantar flexion and those tendons come back closer to each other, there's not a chance that they're going to stick. They're not going to stick.
Got you.
And I think you need those fresh, virginal tendon fibers to touch and say, oh, hello, friend. Nice to see you again. Let's start working on getting better. I think that's the key element.
Sweet. Well, thank you so much for that. That was a huge insight.
Well, thank you.
Great song.
Yeah, great song.
It's been a really, really great conversation. I always learn a lot when I'm talking with you, and feel like we could do this for days. So looking forward to more
Well,
episodes.
yeah, more episodes, and we'll have the content up on all the social apps. Contact us. Do a little plug for your profession and where you are, and how can folks reach out to you?
Yeah, so Unity Physical Therapy, that's my practice. It's based in Los Angeles. Right now I have two locations, one in Venice and the other in Gorda Hills. And I can come to you if needed. If you want any information on it, you can go to unityphysicaltherapy.com and then reach out to me that way.
And you can catch me at Timothy Charlton, CHARLTON.com. A lot of this content will be on there, but it'll be on the social. Everyone, sorry for your injury and hope for a speedy rehab. Signing off. Catch you next time.
Unity Physical Therapy. Rogue.